All right, good afternoon, everyone. Happy World Quality Week. We're thrilled to have many partners joining us today from across the province. And we're really excited to be celebrating World Quality Week. My name is Catherine Charbonneau, and I'm the Clinical Content Specialist for Information Quality, and it is my pleasure to invite you here today on behalf of Born. At Born, we truly believe that quality is everyone's business, and without partners like you, we would not be able to achieve our mission to serve as a trusted, authoritative source for accurate, timely, and relevant perinatal insights that drive improvements for patient outcomes across Ontario. The theme this year for World Quality Week is Thinking Differently. And our focus today is to highlight the many ways that we are thinking differently about information quality at Born. Today, we'll have an opportunity to explore alignment with strategy. So how quality is embedded in Born's strategic priorities. We're also going to be looking at the performance of our system. And so highlighting some different ways that we strengthen data quality and improve patient outcomes just by the ways that we incorporate quality into all of those systems. And lastly, we'll be talking about people and partnerships, which is a really critical role of engaging and achieving high quality data. As a reminder, the session will be recorded. It will be available on YouTube afterwards in case you want to share it with anyone or if you have to pop off early. Additionally, if you have any questions, the question and answer section is open. So feel free to pop questions in there as they arise throughout the presentation, and we should have some time at the end to field those questions. Now I would like to introduce our guest speakers today. Alicia St. Hill is the Executive Director at Born Ontario. Alicia's passion lies in motivating and connecting people, ideas, and systems to spark innovation and create lasting impacts. Alicia is here today to share more about Born's strategic plan and how we're thinking differently about information quality over the next 5 years. Next, I would like to introduce Catherine Menard. She's our Manager of Health Networks. Catherine is passionate about all things related to data capture, integration, and using and improving maternal and child outcomes in Ontario. Today, Catherine will share a little bit about our clinical data integration program and how we're thinking differently about building efficiencies and quality into the future of the Born Registry. And lastly, I'd like to introduce Melanie DeBode. She's a registered nurse and has a master's degree in health informatics. As a regional coordinator for Born Ontario, she supports hospitals and midwifery practice groups and using high quality data to improve maternal and newborn outcomes. She has a passion for bridging clinical practice with that data-driven improvement focus. Today, Melanie will be sharing about the many ways that we engage with our partners and sharing the reasons why we consider quality to be everyone's business at Born. And without further ado, I will hand over to Alicia.
Thanks so much, Catherine. So registries like Born, and good afternoon, everyone. Registries like Born, Ontario, and its contributing partners and knowledge users, we hold a unique relationship in a learning health system. I'm sure some of you are familiar with the slide you see on screen in terms of a learning health system. We do more than create repositories of data. We support turning data into actionable insights, insights that help our system champion quality and distribute new evidence. And in our most powerful form, these insights help us act as connectors, as navigators to and through care journeys, and act as safety nets to identify missed steps in care. We don't only function at the system or organization level, but we also help us see the individual and help us understand their health, their care pathways, and support the care that they receive. On this Quality Week, I want you to join me in thinking differently about how Born, together with our partners, can support care quality in new and different ways. So imagine this: you're pregnant, you and your care team have secure, private access to timely, personalized health intelligence, including your health record, through digital health tools. This intelligence doesn't rely solely on memory, manual processes, or fragmented records. Instead, it's a seamless, intelligent digital pregnancy record available wherever you seek care. It follows you through pregnancy, into postpartum, and into newborn care. Your baby's immunization record is already pre-populated with the RSV immunization that they will receive on their first day of life, and supports you and the healthcare team through postpartum and child health journeys and milestones next. You feel supported, informed, and connected. This is the future solution we are building, a future of connected, intelligent care. At Born, we're stewarding 13 years of pregnancy, newborn, and health data and robust connected infrastructure across our system used by thousands of users. With our partners across Ontario, we have access to untapped technology, evidence, and data that can better support our decision-making and support our commitment to a learning health system, one that uses predictive and real-time analytics to improve outcomes and bring to life the intelligent digital pregnancy record that we've just imagined, and it's conceptually shown on the screen here. When we talk about health quality, and in particular those 6 domains defined by Ontario Health, or formerly Health Quality Ontario, we're talking about care that's effective, efficient, equitable, timely, patient-centered, and safe. And let's take the preeclampsia example you see here. Preeclampsia is associated with about 20% of preterm births in Ontario. It's one of the hypertensive disorders most responsible for poor maternal and poor child health outcomes. What if we could change that? What if we could intervene, truly act like a navigator and a connector? What if we could deploy trusted, personalized tools at the right time, grounded in accurate, available health information that identify individuals at elevated risk based on their clinical and personal history that they don't necessarily need to repeat, but that we know from our health information systems? What if these tools could support clinicians within their workflows and activate the right screening tests at the right time and ensure that preventive interventions, like the intervention bundle seen here that includes low-dose aspirin, reach those who need it the most and serves to prevent preterm birth up to 60%? That's healthier outcomes informed by our registry. And these aren't just distant possibilities. With the right investments and the right partnerships and a commitment to interoperability and data, these tools are within our reach. In fact, we're already working with CIHI to develop reproductive health data standards, and together we're testing how can a registry generate personalized health optimization insights in 4 key areas: the prevention of preterm birth, the prevention of preeclampsia, or identifying those at higher risk, ensuring eligible patients are informed and supported to participate in recommended screening, including our newest screening for fetal blood incompatibility, and support postpartum follow-up for lifelong cardiovascular health risk after gestational diabetes. So where else does quality come in? We know that what effective, safe interventions look like the one I just described. But to truly deliver quality, we must go deeper. We must engage with communities and clinicians to understand how to share these insights and to translate the knowledge we have about healthy pregnancy and children's health in ways that are timely, that are actionable, and that are equitable. We must design and co-design care pathways that are personalized, not just based on the clinical data, but to the lived realities of the people that we serve. That means recognizing and addressing traditional inequities in care delivery. It means ensuring that those who bear the greatest burden of disease, often the most marginalized, have low barrier access to the information and support that they need. And it means respecting patient choice, acknowledging that even with the most advanced tools, some people won't want to participate. We have to honor that individual choice and trust. As we move towards offering authoritative insights on care quality and outcomes, we must take a moral and ethical stance on equity. It means collecting and using sociodemographic data, financial status, housing and food security, spoken language, disability, race, ethnicity, lived experience to improve personalized care and identify opportunities for greater equity. But data quality in this context can only move at the speed of trust. We must build systems and relationships that make people feel safe in sharing their stories, safe in sharing their data, and voluntarily choose not to, knowing it won't impact their care. We must learn about and use trauma-informed care and approaches and ensure that data we collect is used to inform care and improve outcomes, not just for individuals, but for the communities around them. From a data quality perspective, our system holds immense potential, but to unlock it, we must ensure the data is accurate, timely, and standardized. That includes something as seemingly simple as harmonizing lab test codes that we use across the system, like glucose tolerance or an HbA1c test, so that we can use the available real-time data that we currently have flowing that supports human readable lookup. So if someone's on Connecting Ontario, you can easily find HbA1c in someone's pregnancy history or in their history record, but we actually want to fuel system intelligence with that. So that structured data is known to be an HbA1c result, and then it can feed automated algorithms. And it'll have far greater reach, including optimizing care decisions before opportunities are missed. And in pregnancy, we don't have a big window of opportunity to be missing care steps. Data quality also means being able to link and match records with precision. In our context, where 10% of early pregnancies end in loss, it's vital that we can confidently connect pregnancies, even when they occur close together because of resulting in loss, to ensure that timely, accurate insights for ongoing care are reflected on the right or current pregnancy. Accurately calculating gestational age, for example, is critical to informing that we have the right care at the right time. As you see here, pregnancy 3 and pregnancy 4 have very close EDBs, and so distinguishing them with precision means offering the right information at the right time. There's so much to learn and so much more to do. Our 2025-2030 strategic plan is anchored on 3 strategic pillars: modernizing the technology that we use to mobilize insights, delivering authoritative information and insights to the appropriate knowledge users, and driving improvements in screening and care and outcomes. To learn more about our strategy plan, please check out our website, our updated website at bornontario.ca, where we'll continue to post information about our progress towards these goals that I've talked about today. Together with you, our partners, our community, with data and health information technology, we're building a future where quality is not just a goal, it's a lived experience. Back to you, Catherine.
So where I wanted to talk next is looking at our information quality framework. And so sometimes you'll hear us interchangeably use terms like data quality or information quality. And I wanted to break it down a little bit further about what we mean when we say those things. So particularly at Born, our mission and vision is focused on quality. Our goals are to facilitate and improve patient outcomes, to be an authoritative source, so a really trusted, accurate, timely source of information, not just raw data, but turning that information into something that's usable and relevant, and especially mobilizing that information and getting it into the hands of decision makers and researchers and patients as well. So when we're talking about information quality at Born, we're referring to our information quality framework. And it's these 5 pillars: timeliness, accuracy, comparability, usability, and relevancy. And these principles really guide everything we do to support quality at Born. Particularly, we aim to receive data as soon as possible. So in terms of timeliness, we really want it to be information that's coming from the greatest source of truth, such as clinicians, labs, clinics. And when we review that information, we like to validate it and refine that. We want to remove errors. We want to identify outliers and especially trends. And when we transform raw data into timely and accurate, relevant information, we hope to share it in forms of reports, dashboards, and then especially for research, with the goal of ultimately providing information to decision makers, whether that be patients or at a hospital level administrative for planning purposes, but also looking into research and ultimately improving outcomes across Ontario. When we're talking about timeliness, we really mean that the information is available when you need it. In particular, if we look at prenatal screening, it's that our results are uploaded promptly so that clinicians can act quickly to support real-time decision-making with families. And that hospitals could receive monthly performance dashboards to monitor trends or quality improvement projects. Currently, timeliness is really focused on our most current up-to-date information, and we hope to share that back in a meaningful way. When we're talking about accuracy, what we mean is that it's reflective of what the care that was actually provided. And so to Alicia's example, we're talking about capturing gestational age, that it actually trickles down through multiple pregnancies. And that information that we receive, we want to be able to make sure that it's accurate in many places within a patient journey. Particularly when we're looking at prenatal screening and an expected date of birth. So some of this information is very specific and it needs to be accurate so that when we're reporting it out, it makes sense. When we're talking about comparability, we really mean that consistency over time, that it looks like when we compare it to other sources, that it even looks more true. It helps us say that it's a trusted source when it can be compared to something else. And so particularly, we would use standardized definitions for postpartum hemorrhage across all hospitals so that we could really capture the most accurate rates. Maybe for hospital managers, you might have benchmarking for C-section rates across the province or across historical prevalence rates to see how your site is doing. And then particularly with decision making. So sometimes we'll have comparators between national health data sets for trending analysis, like with the Canadian Institute for Health Information, CIHI. Comparable data really allows us to measure and to offer improvements. So we often use comparisons to make data look more meaningful over time. And then the last two tenets of our information quality framework are usability and relevancy. And what we mean is that we can make the data actionable. We design tools that should be intuitive, that they should be able to provide insights with little need to interpret, that it's obvious what information is being pulled and shared because it's clinically relevant, that it makes sense to the work that we're doing on a daily basis, but it also, in comparison to your own knowledge of your site, that it also makes sense, that it's clear and concise, that we're able to turn the information into something that's visually pleasing, that when you can look at our data and turn it into information, that it's obvious what we could do with trends over time. And that's really our goal, is we're constantly collecting all of this information, but ultimately it's that we're trying to turn it into information that's meaningful. And now I will turn it over to Catherine Menard.
Thank you. It's an abundance of Catherine here at Born Ontario. So I will quickly talk about the performance of our system. More specifically, how we collect data, what kind of performance metrics we have, and continuous improvement for data collection. So currently we have 3 data entry methods. There's the manual UI, where end users can enter data directly in the Born information system. We call it the BIS, and you'll see reference to that acronym in the next few slides. The major pro for this data entry method is that the end users get immediate validation. So there's interaction with the system to validate the data and know what's missing from each of the encounters. But the biggest disadvantage is a high data entry burden. So all the clinicians enter in their own EHR or their clinical charting or the lab information system, and then they have to re-enter the data in the Born information system. We also have a file upload. It's a batch submission on a flat file from that is extracted either from the electronic health record or the lab information system. The advantage of this method is that a lot of records, so a large volume of patients, can all be uploaded at the same time. And a disadvantage for this method is that it requires a lot of formatting and correction of the records directly in the flat file to be re-uploaded in the system. And lastly, we have clinical data integration, so HL7 feeds, either ADT or clinical messages. I'll go over ADT in the next few slides, of near real-time events that are transmitted from an EHR or an LIS in the Born information system. One major advantage is that it's an automated process, and it's aligned with the principle that the data is collected once and then transmitted and used multiple times across different systems. A disadvantage of this method is that it's a complex integration that requires a bigger lift at the beginning when we're implementing these HL7 feeds. This is a screenshot of the biz. So this is a labor birth encounter where the end users could click on all these tabs and all the variables would be collected through this window. This is an example of a CSV file for a maternal upload. So you can see just the beginning of the upload file where each line would represent one person and each column represents a variable that is collected in this data set. And lastly, I don't have images of proprietary EHR or LIS, but HL7 feed is a direct interaction where clinicians are documenting what they would usually document in a health encounter. So a labor and birth event, they would chart directly in the EHR, and all these variables would be transmitted directly in our system. And to get to this point, as Alicia mentioned earlier, we need to standardize the data set so that all these variables that we're collecting in the registry are part of all of the EHR build, and it's easier to transmit data and collect data if we all speak the same language and all the base variables are already collected in the system. These are all of our data providers, along with all the different data entry methods. So you can see that depending on the data providers, they all have access to different data entry methods. And more, there are some projects to integrate HL7 feeds directly in our system. ADT represents data that are related to admission, discharge, and transfer. These messages are not meant for born specifically. They are generated by EHR system for many different organizations and workflow in the healthcare continuum. They contain mostly demographic data. It reduces a lot the manual demographic entry for midwives, for example, because they all enter their data manually. And if an hospital is integrated with ADT, they would have access to a work list that I will show in the slide right after. And then they can pick the patient directly from the work list and not have to re-enter all the demographic data and then create a patient. It also reduces the duplication of patients because you pick from something that already exists in our system. The work list can also help identify the encounters that are entered in the system. So this is what the work list looks like for the perinatal data set. So how are we thinking differently to ensure seamless data exchange and also to reduce the duplication of data entry between multiple systems? We use pre-population rules. This can help at the time of the encounter creation, pulling data that already exist in other encounters so that the variables don't have to be entered twice. This is really beneficial for our manual data providers. And there's also auto population rules. This is implemented, so it's pulling data from different variables, data that represents the same thing. So for example, the primary reason for induction could be used in all indication and not asking the users to duplicate their data entry efforts. So those are ways that we're moving towards to reduce the duplication of data entry. And these are just a few performance goals that are more related to the perinatal data set. Born collects a dozen different data set, and they all have different performance goals depending on the timing at which they're being collected and they're being processed to extract insightful information out of them. But for the perinatal data set, one of the performance goal is for all of the babies to be created within the first 7 days after the birth. And this contributes to the participation in the NSO miscreen alert. So every day the biz will pull all the babies that are 8 days or older and that are not associated with a newborn screening encounter. And this can indicate to NSO babies that could have missed their newborn screening. And this is one of the critical alerts that can be issued from the biz. And one of the reasons why it's important for us to have timely data on babies. Another performance goal is to have all the records submitted by the 15th of the month for all the births that occurred the month before. And this allows us to turn information into useful reporting products and have fresh data available to the data providers. And now I'm going to turn it to Melanie to talk to us about people in partnership. Thank you.
Thanks, Catherine. All right, so you have heard about how quality is aligned and embedded within Born's strategic priorities and organizational goals. You've also heard about how our information quality framework and example initiatives we are working on to improve our quality and performance. Now we're going to shift gears and we're going to talk about the people component of quality, and that is truly the foundation to all the work that we do here at Born. So what do we mean when we talk about the people component of quality? At Born, we work with people and partners at multiple levels. Starting at the outer circle, we work closely with system partners to prioritize and collaborate on quality initiatives in Ontario. But we also work with organizations such as hospitals, birth centers, midwifery practice groups, laboratories, public health units on more local quality initiatives, including the use of data for organizational improvements. And finally, in the inner circle, we work with a diverse group of individuals embedded within our organization and system partners. And these individuals are truly the backbone of the work we do. And Born supports these individuals to build capacity to enter data, improve information quality, and apply data to improve care and outcomes. Although this slide just shows a very small sample of our partners, the key takeaway message is that high quality data and information rely on active and meaningful engagement with all levels of data partners. With that foundation in mind, let me walk you through some real examples of how working together with our partners drives meaningful improvements in quality. When we think about data quality, we often picture systems, dashboards, and reports, but at its core, data quality is a people process. Every stage of the data journey relies on people, from nurses and clerical staff entering information, to quality teams and educators reviewing it, to managers and leaders using insights to drive change. And that's exactly where our clinical engagement team comes in. We're a group of regional coordinators, clinical content specialists, and one knowledge translation specialist. And our role is to be the bridge between the registry and the hospitals and midwifery practice groups across Ontario. And engagement is not a single moment. It happens all along the data journey. It starts before data is even entered, when we talk about documentation and workflows, and continues as teams use their data to generate insights and take meaningful action. At every step, we're building relationships with leaders, clinical teams, educators, and frontline staff, helping them turn data into action for quality improvement. So how do we do this? This slide highlights our three main approaches. Connecting. So we meet people where they are during site visits, virtual meetings, through reports, or sometimes just a quick check-in to help troubleshoot an issue. Communicating. We keep the conversation going through the Born Brief, which is a newsletter, webinars, emails, and through the Born Information System messaging feature when we need to share personal health information securely. And lastly, by collaborating. We work alongside partners with the Born Collaborative, external committees, and advisory groups to support shared learning and system improvement. And all of this creates a continuous feedback loop where people are learning from their data and data improving because of people. One of the most powerful ways we bring engagement to life is through site visits. And these visits give us a chance to move beyond emails and reports, to sit down with teams in their own environment, understand their workflows, and have real conversations about how data can support quality care. We also use this time to reflect on how the data contributed by each center, practice, or lab informs provincial initiatives and analyses. It's a unique opportunity to connect with various individuals, and each of these individuals sees data from a different perspective, and that's what makes these visits so impactful. Site visits help build relationships across roles and departments, and so when a director, a manager, an educator, and a bedside nurse comes together in the same room, it creates an opportunity for understanding. With site visits, we can help bridge leadership vision with frontline realities. No two visits will look the same. We tailor each one to the organization, whether that's about priorities, the culture, and current stage on its data journey. For some, that means discussing workflows and overcoming barriers, and for others, it's about celebrating progress or finding new ways to make documentation easier. When people see their data come to life, it sparks a sense of pride. They realize their documentation tells part of their hospital's practice, lab story, as well as Ontario's story. People start to see themselves in the data and how care quality is measured across the province. Site visits often also start a chain reaction. Managers and educators bring discussions back to team meetings, and nurses share documentation tips with one another. Each person plays a part in improving data quality long after we leave. And by taking part in site visits, we're building a network of people who feel seen, supported, and connected in their role in improving data quality. The next example we will share focuses on how we are working to build strong infrastructure to facilitate engagement with data partners. Learning from our data partners and incorporating their feedback are essential to improve the quality of our processes, but also our products. For example, it can help us better contextualize and understand data quality issues, to improve our data collection and reporting systems, as well as identify areas where we can improve the use of data. Data partner engagement has always been part of our day-to-day work at Born, but we saw a need to improve our engagement mechanisms so that we had easier access to a broader group of data partners who could offer timely feedback on our initiatives. As one step towards creating more infrastructure for engagement, we developed the Born Collaborative. The Born Collaborative includes over 80 data partners like midwives, nurses, health leaders, work clerks, informatics specialists who have agreed to be contacted to offer their input on key initiatives. Throughout the year, we reach out to collaborative members to ask for their input on our projects and our products. For example, we have asked in the past members to help us understand what challenges they encounter when submitting data and why we are seeing so many unknowns being entered for a particular data element. We've also asked for feedback to improve the usability of our products, including asking members to review a new data entry screen or a report and tell us if it was easy to use and understand. This information is then integrated into our project decisions and ultimately improves our products and processes. The examples of Born's in-person site visits and the Born Collaborative illustrate how we are thinking differently to broaden and deepen our engagement with our data partners. The foundation for improving care and outcomes for pregnant women and people, infants, and children begins with access to high-quality data and information. Achieving that level of quality is only possible through the dedication of all our data partners and their ongoing efforts to collect, enter, and use data to drive better care. So we will close this segment with a big thank you to each of our data partners for your ongoing commitment and collaboration in improving the quality of our products and processes, and ultimately our impact at Born. Back to you, Catherine.
That's great. Thanks a lot, Melanie. We now have some time for questions, so feel free to type them into the Q&A section. You'll see up at the top, along the top label bar, and we'll do our best to answer the questions. We'll give a few moments. We have no questions queued up currently. Feel free. And otherwise, thank you very much for joining us today. It's nice to have an opportunity to connect in this way, and we hope to have an opportunity to do more webinars and kind of reach outs in this way. I do have an evaluation that you'll receive after this session, and we're really looking for feedback on future ideas, anything you'd like to see from Born that would be really relevant for your site.
I believe you can also, people can raise their hands too, and we can unmute them if we need. So if anyone would prefer to ask their question by coming off mute, we can facilitate that as well.
No brave souls today.
There's a question in the chat, Catherine.
Oh, great.
That's great. Great
For
question.
some reason, I do not see it, but
Oh, I can ask it then.
yeah,
And I think this is a question for Catherine Minell. Is the ADT, or admission discharge transfer messaging, and pre-population bi-directional? So I think they're also asking if we can populate the EMR with information that we have.
No, not at this time. It is not bidirectional. We are receiving ADT messages, and we do not pre-populate any of the values that are submitted in the Born information system back in the EHR. So for the moment, ADT and pre-population are unidirectional in the viz.
And I'd be very interested, Christy, if you also want to share with us any thoughts about what you might want to see hit back towards your EMR. That is a very great question.
Mm-hmm.
No one else? Well, we'll certainly appreciate everyone's participation in coming and joining us today. Please check out bornontario.ca. You can sign up for our newsletter. You'll find contact information for us if questions emerge for you in the days following. We definitely welcome your insights and your constant feedback with us. So thanks again for attending.